primarily use global with lysis and platelet mapping, but it's kind of an FYI. I just want you, because we're starting the whole new kind of system, I want you to be aware of what you will have available.
So we'll go ahead and welcome our speaker this afternoon, Katie Bosard, is replacing Aaron Roberts, who got a promotion implemented. Look forward to your talk.
Thanks. Yes, I'm Katie Bosarge. I am based locally in Nashville, but I am very familiar with Chattanooga. I went to school here, did nursing here for a while prior to moving back to Nashville. So I will leave my cards and things as far as contact info, but yes, I will be replacing Aaron and supporting the TEG program here. So we'll get started. We're going to talk about the TEG 6S, which is the device upgrade that's coming. So I include the kind of next two slides here primarily to just kind of review the main guidelines that include viscoelastic testing cut points here. So kind of well-known SCA as well as SABM there in the middle for resuscitation of all the kind of major blood products, as well as in the setting of traumatic hemorrhage. And then more relevant to the trauma team, we are kind of in the TQIP guidelines there for viscoelastic cut points for transfusion triggers, as well as on the kind of blood management side. And so systems, this picture is kind of just to show you where we're coming from to where we're going. So the TEG 5000 currently lives down in the laboratory. That's where the samples are, being run right now. It does require kind of manual mixing of reagents, and there is a little bit of a time constraint associated with those samples. And the upgrade will be to the TEG 6S, which is a cartridge-based device. So you will get 4 tests in one. It's no longer an a la carte ordering style, and everything will kind of show up on the screen there in the lab, as well as in TEG Manager, which will be a new viewing software that you guys will have. But I just like to show people that it is quite a nice upgrade from old to new. And so just for review, I'm not sure, I don't know if we have students and all the things. I just wanted to go over kind of the main utility of TEG and juxtaposing the limitations of traditional coag tests. The kind of graph will grow here, your traditional coag graph, and across the bottom, you'll get the lab values that you're most frequently ordering and seeing. And really what they do, it's a plasma sample. So it provides a semi-limited view of how all of your blood components interact in vivo. So it is that kind of spun down limited sample view for the kind of time points you're most familiar with across the bottom, and maybe not the most accurate depiction of your patient's overall hemostasis. So enter thromboelastography, or TEG, that's what it stands for. And this is a whole blood analysis. So we kind of grow the clot and measure its properties, and it gives you a little bit more functional parameters here. So a graph as well as numbers that you can evaluate for treatment. And so the main parts of the graph that will grow are your R, standing for clot rate, measured in minutes, MA, standing for maximum amplitude, measured in millimeters, and then LY30, which stands for lysis at 30 minutes beyond that maximum strength, and that's represented as a percentage. And so there are 3 global hemostasis cartridges that we will be getting with the 6S platform. So I put big stars next to the trauma cartridges that you all will be using, and then the global hemostasis up in the kind of top corner here is our cardiac cartridge. And each of them contain kind of 4 or 3 assays in one, again, a cartridge instead of a la carte. And so an example of TEG 6S trauma protocol here. So on admission, I understand you guys run typically platelet mapping and global with lysis. You have certain criteria for those patients. And that is on admission to answer the important questions about baseline hemostasis. And so identifying coagulopathy early, identifying platelet dysfunction early on. And then during the MTP, sometimes people, it's just kind of per institution. I'm sure we'll take a look at, I know you guys have a pretty well-tuned system here, but kind of as needed during the MTP to continue to tailor the resuscitation process. And then post-operatively, as you've kind of gone to fix any sort of mechanical problems, to evaluate global hemostasis. We'll go over the cartridges in just a minute, and I'll kind of show you how they'll show up in Epic. But GH with lysis is the cartridge. That's the trauma cartridge. So we'll talk, that's my next slide. And so post-operatively in the ICU to monitor kind of the continuing coagulation and hemostasis picture. And, once we've massively transfused them, have we swung the pendulum, or they may be now at risk for the hyperthrombotic side of things. So now we'll talk about the global hemostasis with lysis cartridge. So that's going to show up GHLY most of the time, or TEG GHLY, or TEG GH lysis. I don't know how they're going to write it in Epic yet. That is I will follow up. They're still making the orders within Epic kind of this week. I've been in conversations about that. The cartridge, again, has the 3 tests in one. So saturated kaolin being the sample that you guys run right now, a la carte. It gives you all of the parameters. So R, K angle, MA, LY30 will all still report out in that saturated kaolin red tracing. Saturated rapid TEG, I believe we do have that available here. I'm not sure how often you guys utilize it, but ultimately it's a more rapid evaluation of overall clot strength, looking at platelet and fibrin contribution. And functional fibrinogen is a true fibrinogen assessment. So it sort of replaces the K and angle, which are surrogate markers for fibrinogen. And so we can look at the CRT and CFF MAs to evaluate platelet versus fibrinogen need. And so how these will look together within the viewing software are kind of juxtaposed on top of one another, with the color coding being unanimous throughout. So from the analyzer to the viewing software, all the colors remain the same. So any questions about that, or naming or anything like that? So TEG Manager is going to be the viewing software. The calls I was on yesterday were building a link within Epic. So it'll kind of be on the toolbar at the top of Epic for you guys to access it. I believe they're also going to include it on the intranet page. There'll be a way to kind of get to it there, but it's browser based. So any any facility computer or device that has VPN access, you'll be able to pull it up. Yes, you can. It's not computer specific the way the kind of old software is, if that makes sense. How you have to go to the right computer to make sure you can get to the picture. That problem is gone, which is nice. And we'll talk more about TEG Manager. And so again, talking a little bit more in depth about clot rate, what does it show you? It is evaluating factor contribution to clot formation. So does this patient need FFP? And then also in this, you will capture lysis as well. It grows on to give you your lysis percentage in that, again, that saturated kaolin sample. And then looking at strength side by side, we look at the rapid TEG MA as well as the functional fibrinogen MA side by side. So rapid TEG, again, showing us platelet and fibrin contribution, and CFF MA has an antiplatelet medication in that test that turns off the platelets in that sample and truly does just show you fibrin contribution. So if your CFF MA is low and your overall MA is also low, you could discern that fibrin might be the likely cause if you were seeing bleeding and the patient may need cryoprecipitate resuscitation. Conversely, if your CFF MA is normal, but your overall MA is decreased, you could discern that platelets may be needed if the patient is bleeding. Any questions there? How we look at those together?
Turn the platelets off.
With abciximab. So we put ReaPro in the actual test in the cartridge. I'm bringing it together. So again, this is just how they show up on top of each other. I'm a visual learner, so I like to include lots of different ways. So, and this is a badge buddy. So I've got to bring more of these, the lysis badge buddies. So I'll make sure I drop them off to the university offices. We'll get them out to you guys. But truly, you've got the kind of main reference ranges at the bottom there listed face up, as well as your hypo and hypercoagulable ranges right there, just as an easy, quick reference. All of this kind of normal reference range values are also listed in the TEG Manager software. So no need to commit them to memory. They will be available for you. And on the back of the badge buddy, you will also find this handy dandy graph for kind of out of the parameter changes and then potential considerations depending on what results you're seeing. And so another thing to mention, is it going to grow? Yeah. So these are still being collected in the saturated blue top tube. So these global hemostasis with lysis samples and the global hemostasis cartridge samples will still go in a saturated blue top tube. So no change in that workflow. Typically, I think limitations that come with citrated tubes are to do with the manufacturing of the tube. So the reagent that lives in the citrated tube, they want a certain amount of blood in there so that when it mixes, it anticoagulates appropriately. I would say best practice, still fill to the line, but you can use pediatric tubes. You can use whatever size blue top tube. It takes less than an ml of blood to run the cartridge. So there is flexibility there as far as how much blood you want to send. You can do it in a smaller blue top if you want. So point of care, I think they're still working to answer that question. It can go to the point of care, yes. I don't think we've started having that conversation yet, though. So we can talk to the lab if you would like, definitely. In a fanny pack. Okay, so I like to include, again, case samples. This is how TEG Manager will show up for you guys. So kind of case picture there, 37-year-old car accident. This is how she came in. This is what her TEG looks like. So abnormal values being called out pretty handily with our, bright orange banner there. Hey, look at these. They're a little bit out of range. So we can look at our kind of rapid TEG and functional fibrinogen lines as maybe being a little low here. And so are they in an optimal coagulative state? Probably not. And then discriminating the likely cause. So if we reference our normal ranges there, we can see that the rapid TEG MA overall is much more out of range than our functional fibrinogen. It's just 0.8 out of the kind of normal there. So again, if our functional fibrinogen is looking pretty normal, but our overall MA for rapid TEG is decreased, we can discern that if the patient is bleeding, platelets may be the likely cause. And so how quickly could we determine this? I like to now highlight the white line there. So actually, I'm sorry, I don't have a mouse, but the white line, 10 minutes, you can kind of see the grid at 10 minutes or before 10 minutes, you could see that your blue functional fibrinogen line was growing right in the middle of 0 to 20, so maybe 10, 15, and your purple rapid TEG tracing is below 40 there, which we know before 10 minutes, basically that it's going to be resulting out probably lower than we would want. So before 10 minutes, we had actionable data. You asked about watching it grow in real time. That's the utility there, is pulling it up after you've sent it and physically watching the graph grow. So you can know more quickly. And so we discern that platelets are the likely cause if this patient is bleeding. And because we live in a perfect world, everybody, we've identified it quickly and did exactly what we needed to do. We've transfused platelets. And are they now, retested the TEG? Are they now in an optimal state? At the 10-minute line, again, we can see we are right, kind of the functional fibrinogen right at 20. Go ahead. You can, there's no like equilibration period. Once you treat, you can test. So we do treat, test, treat, test. So once you've transfused, you can resend immediately. Whatever makes sense for you guys. So that truly, it's the time points that are meaningful to you is what I would say. And so the rapid TEG MA again at that 10-minute line is nicely above 40 there. So again, we've kind of come up back towards normal. So I think I've gotten ahead of myself there, but now we'll talk about platelet. Sorry, any questions there? Viewing software wise, thank you for your good questions. Just want to make sure I'm stopping. Okay. And so for platelet mapping for you all, so we know that there are many, many potential causes for platelet dysfunction. And this, again, is 4 tests in 1. I would like to stop very quickly and highlight a change in you guys' workflow. We are going to build an order that combines the platelet mapping as well as the global with lysis cartridges, but no longer. So the HKH sample that grows here will not report out the lysis value. So it grows completely like a citrated kaolin sample does, but it does not evaluate lysis, if that makes sense. So the substitution here is global hemostasis with lysis plus a platelet mapping cartridge. So I guess the way that they will build it in Epic is a link between the 2 cartridges so that is what shows up for the patients that you want to evaluate global hemostasis with lysis as well as platelet mapping. There will be an order to select that. There will also be a la carte. So for patients that you do not want to evaluate platelet mapping, you can order that individually. And so that is kind of just the way that will be in Epic in the I guess, your kind of lab sheet that goes in the trauma order set. So that is a change. It will still be just a green top and a blue top, but it is kind of two separate cartridges to get the same information that you have now. Go ahead.
I'm sorry, can you explain that again? So if we want platelet mapping, we have to order the citrate kaolin tag and then a platelet mapping separate?
It won't be separate. So the way they're going to, because we understand right now that you guys order a tag with platelet mapping. So the way that we're going to build the orders now is you will still get the same information, but what that will look like is a platelet mapping cartridge and a global hemostasis with lysis cartridge. So it will be 2 cartridges for the one order before, because the 4 channels across the TEG 5000 could run everything all at once. And so you get more info from the global hemostasis cartridge. You're getting that functional fibrinogen and rapid TEG, where before you did not. So it's kind of just the way that the sub worked on the cartridge-based system. 1 per device, but you will have 4 devices down there.
So are you getting rapid tag results with that or both?
You're in the global hemostasis with lysis cartridge, you will get all of the results here in one. No, that's okay. All of these will result. So you will get your citrated kaolin, you will get your functional fibrinogen, you will get your rapid TEG. So this is the equivalent of 1 cartridge, global hemostasis with lysis. And so no, that's okay. We will also, so it's kind of in addition to, right? So for platelet mapping, it's just a separate cartridge of the 4 tests that make up platelet mapping. Does that make sense? And we're building an order in Epic that will include both of them. Because I know that like checking boxes, it's like, oh, kind of menial, but there will be one that includes both, but there will also be a la carte options for you guys. If you don't want to run platelet mapping, or if you just want to run platelet mapping, but you don't care so much about lysis. Other questions? I am not sure. I know that you guys, they've done sort of a specialized pricing just in general for the hospital. But I think it would probably be between $60 and $80. There's no. So for the cartridge system, there's no way you're going to get all the data every time. Does that make sense? So what was your question?
I guess what's the difference between a GH assay and then adding the platelet manager?
It's just the addition of the rapid tag and functional fibrinogen data.
So you're basically paying for $100. The GH is our normal tag. It doesn't have. The mapping is a separate one. So on patients, the 21-year-old that doesn't have a head injury doesn't need to play the mapping part. But that 8-year-old that falls may not need stasis. Right. Well, yeah, right. They're not.
Good question.
Okay.
So you do have to be considerate of what the patient is and not just order both every time.
And that's why we're building it that way. So it's going to be easy if you do need it. You can select both, so you won't have to go and manually do one. I don't know. They just told me the workflow that we needed to link them in Epic. That's what the red shirts asked for. That's what they told me. That's how they told me to build it. But then they also expressed that it was important to include a la carte options for the cartridges, like per cartridge. So I will certainly send you more info about how this will actually be listed within Epic when the order team gets back to me with all the data there. And so for platelet mapping, this is data that you're very familiar with. So it's 4 in 1 here, but it's a cartridge again, rather than the 4 channels. So HKH representing our baseline full platelet participation, activator F representing our baseline no platelet participation, and ADP and AA representing how your patient's responding based on the different agonists there. ADP mainly showing there's tons of kind of underlying patho things, but also P2I12 medications, GB2B3As, those kind of common antiplatelet meds, AA capturing aspirin. And so it's a comparison of MAs. For those of you who are less familiar, we'll compare how our patients' ADP and AA tracing is growing in between the two baseline tracings there. So only your really MAs will grow. And so considerations just for percentage inhibition versus aggregation, and why inhibition and measuring it is so important is because everybody's baseline is different. So I just like to include this slide just because, as you all know, everybody's kind of baseline inhibition looks very different. If I walk in and I'm 50% inhibited, maybe I'm now still hypercoagulable, but someone else walks in and now they're at, an extreme risk to bleed. So platelet mapping is, again, a very useful tool there. And so preoperatively, prior to intervention, as I imagine how you all run it, I assume I've seen, your protocols. I think it's transfusing platelets pre-intervention there. But then postoperatively as well, it's something that from the other side, once we've corrected all these problems and transfused, are they going home on medications that make sense for them and are working for them to kind of make sure that they are not at risk to clot when they're going home. And so this is what it will look like inside of the viewing software here. Our graphs will grow, again, color coordinated throughout. So baseline full platelet participation, baseline no platelet participation, and ADP, how our patient is falling between those baselines. So in this case, you can look at the MA value here and discern that the HKH MA 66.8 is very similar to the ADP MA there, right at 63. And so this patient would be considered minimal inhibition, which is also listed across the bottom there. So percentage inhibition, percentage aggregation, also being verbiage to be familiar with. And so, sorry, I got it there. So any questions there? Okay. And so next, this will be kind of our inhibition sample. Again, the kind of called out abnormals with the different arrows, baseline full platelet, baseline no platelet, and how our patient is tracking between those two tracings. So this patient would be considered pretty inhibited here. So if they were going to surgery tomorrow and we could change the timing, that would likely be what we would do. They would be considered at a significant risk to bleed. Again, across the bottom, you'll see that they have a higher percentage inhibition as they're tracking towards that no platelet participation sample. Any questions? And so now we'll talk just briefly about the global hemostasis cartridge. Again, this is primarily for the cardiac patients, but I just wanted to mention because the whole system is new to you all, sorry. And so you will also see this likely in your Epic ordering screen. So CV testing protocol, again, those baseline samples, as well as global hemostasis throughout for patients being treated with heparin to answer important questions about their hemostatic profile. And so this is, again, a cartridge of 4 tests with the saturated kaolin, rapid TEG, and functional fibrinogen. But we do have the saturated kaolin with heparinase or heparin reverse sample that we compare the R times for the CK and CKH to discern a heparin effect. And so this is how they look within the viewing software here. Again, all the color coding unanimous. And this is R times. So for the green and red lines, Christmas colors go together is kind of how I like to say that. But the heparin reversed sample and the heparin sensitive sample, if your patient, you don't want them to be, you don't want to see the lines splitting differently. So if there's a difference of greater than 2 minutes or more, or a delta of greater than 2 minutes in R times, that is significant heparin present in the sample. And if you would consider redosing protamine rather than transfusing FFP, you want the green and red lines to split right on top of each other. That would be a non-heparin effect. And then again, looking at MAs to guide platelet and fibrinogen resuscitation, bringing it together, see the graph. And then I have, this is the badge buddy that goes along with these. It's essentially the same, you just don't capture lysis in this cartridge. So that's the main difference. I just wanted to include this in case you're ever in a clinical situation where you can give me a call if you have questions about what you're wanting to check out, and we can go through it together. But it is the kind of only difference here is heparin reversal and lysis evaluation. Yes, so that would be the workflow would be to order this one. You could look at the R time difference there. But the other data, if the patient's being treated with heparin, we don't actually have a tag right now. Like the cartridge is not out yet. That is all the way heparin reversed. So that is a limitation of this platform.
Particular cartridge is more for your ECMO type patient. This is the GH. This has got GH with license.
Yes.
So there's essentially 3 separate cartridges.
Correct. And the lysis cartridge is our trauma cartridge. So this is not going to give you lysis. It is rare in a clinical situation that you all would be using global hemostasis. I just included it because the whole platform is new and I wanted you guys to know so that when it comes up, just know that you're picking the lysis cartridge. Global with lysis and platelet mapping. That's the wording. It's just new. So I just wanted to make sure you had the info. And so this is how it looks here. This is a cardiac clinical example, but for the heparin effect here, just wanted to show you the kind of lines splitting on top of each other there. And that would be a kind of negative heparin effect, or the difference in R times is not greater than 2 minutes. And I'll click through these next slides here. I'm going to talk about TEG Manager next, if that's okay. Again, the global hemostasis cartridges are collected in saturated blue top tubes. Platelet mapping is still going in a heparin green top tube. Any questions about collection? Size, again, is not the limiting factor. Pediatric tubes are okay. All of the cartridges take less than 1 ml of blood to run the sample. And so TEG Manager will be the browser-based software that you all use to access these tracings in real time. You can do it from anywhere that has VPN access. So we can get it set up on your phone if you have the VPN on your phone. If you're walking down the hall, you want to look at it. But I think ultimately the deployment will be, again, through the kind of top bar within the toolbar within Epic for all of our kind of critical care and surgical critical care providers. So it will just be there for you all, as well as the intranet, and your login will be the same as what you use for Epic. And so that is kind of, I'll keep you updated on the formal kind of access for what that process will look like. And then for the banners here that you see, the kind of red interpretation guidance is what that's called. And so my goal is to kind of work with you all to set up parameters that are meaningful to you. And these banners will populate in real time to kind of give treatment considerations if that is something that would be beneficial for you all. So it's kind of pops up in TEG Manager as you're watching the graph grow, and it can say, hey, your CFFMA is low, consider cryo. So it's just kind of a way to give a more tailored sort of standardized response based on results. And then let me see if this link will work on here. Oh. I wanted to walk y'all through TEG Manager very quickly. Oh no. I don't know if this one is connected to the internet, like it'll let me. So you will log in with your same credentials as Epic. I just had to change this password. So hold on 1 second. I'm literally going to go to where I wrote it down. My apologies. Okay. Anyway, so in the kind of time, I don't want to take up all of your time here today, but it is the time order. The most recent tracings will populate up at the top. You can select today. It's very easy to kind of navigate. I'll do a screen grab once I have the info about how we'll access it here and kind of can share it with you guys. But truly, it is very easy to navigate. You can search by name, patient birth, so name, birthday, all the regular identifiers, or just by today. So knowing that you've just sent a sample, usually the workflow that we do is just check today box and then the most recent being right up at the top. So easy for you guys to get to. And again, those messages being something that you guys' team can help create. So I will kind of reach out again and we'll get those set up with the lab team just to identify the ranges that mean the most to you guys. Any questions about TEG Manager? I'll have more info again about accessing in the coming weeks. They're still downloading the server. And so supporting clinical outcomes with TEG, reducing blood product usage, stratifying thrombotic risk, and identifying platelet function again, the primary kind of utility there. And then this is my contact info. I'll leave my cards in the back, but if you want to just snap a shot of that, that's why I'll include it here. That's my cell number and my email. If I can provide resources to you, I've got a folder of kind of the main digital things. I know sometimes it's easy to lose physical copies, so I'll send you some badge buddies and reference material via email or whatever's easiest for you guys. I'll put it in a folder, pack it up, and make sure you can have it or you can get to it. So questions for you guys?
I guess one of the things that I'm curious beyond something like our septic patients, liver issues, you're on the spectrum of that. I guess weird thing. Quite a lot of these.
So as far as, oh, sorry. So medicine related, you capture anticoagulant medications, and at least for liver populations, anything that kind of comes from that prothrombotic versus not specifically stemming from liver dysfunction or hepatic patients in your R time still. The difference being that right now, as far as heparinase cup used to be what those samples were run in, we don't currently have a cartridge that can reverse all of the channels. So you can run a global hemostasis sample on them and see their underlying R time, but the rest of your TEG will not result. So that is still a limitation that we have as far as if you have a patient that has a lot of kind of endogenous heparinoids, things like that. There's a cartridge, there's not a cartridge right now that we can run that would give you all of the TEG info for that patient, just in our time.
Okay, so you can reverse heparin with these new cartridges or not?
You can. In the cardiac cartridge, there's one heparin reverse channel, but the heparin reversal is captured only in the R time that reports out. So it tests sensitively and specifically for the presence of heparin, and we compare R times for the need basically to redose protamine. You're not getting the full CK tracing reversed. No, not that I can share with you at this time. I'm sorry. The platelet, it's so just for what it's worth, the platelet mapping HKH sample, it's not a saturated kaolin test that you're running, but it is a heparin reversed channel. So you're not going to get your RK angle MA LY30. You're only going to get your MA tracing. So you're not going to get all your data, but that has been a workflow that people have used because like your TEG platelet mapping that you're used to getting with the full TEG information as well as your platelet mapping information, that is still captured in your baseline tracing, if that makes sense. So your HKH is a heparin reverse tracing that's in your platelet mapping cartridge. It's just not going to give you numerical data to give you your RK angle MA LY30. Numbers, yeah. Yeah. These are And in platelet mapping, we use the heparin in the sample to turn off the thrombin. And so that's how we stimulate the platelets specifically there. And so it's not dissimilar. It's just that you don't get the numerical data. So like he's saying, if you can look at the graph, it's not a one-to-one, but until we have the fully heparin reverse kind of cartridge and I'll keep you all updated on that info as well, of course.
Any head-to-head comparison of the liability 5,000 to the 6S, and as far as data reliability, we've been playing for years now, looking at net results. Has anybody done anything with this new cartridge function? Is how much better this test is.
Turnaround time being, yeah, the main kind of thing. We have two major studies that are in the kind of, I don't know, clinical trial phase that are specifically looking at TEG success in the trauma patient population. But they are not, as far as I know, have been published yet, but they are partnering with us so that we can make kind of condensed, obviously good use of that data. So there are people doing it right now, but I can certainly put you in touch with our medical science people. It is likely that they are aware of more than I, but I know of two that they're doing right now. I will be here for case support for 2 weeks after the clinical go live. So I'm sure I will see you all again, probably before you even have time to miss me. But truly, if I can be a resource to you, or if you have continued questions, I am here to be a resource. So I will be here for both trauma and cardiac case support as that clinical go live happens. So I'm happy to help however I can. They were telling me mid-April, again, pending IT, again, the server build out right now, we've kind of got everything in production. They just kind of have to get everything lined up and turned on. I don't know that's kind of like that conversation, at least everybody's Epic looks so different. And so I think the Epic team is communicating with the internal kind of Humanetics team right now to get everything downloaded and turned on. But I'll certainly keep you all updated of the more definitive go live date, but they're telling me mid-April as of yesterday.
All right, thanks.
You're welcome. Thank you guys so much. Enjoy the food and have a great rest of your day.